All right, so we're going to pick back up talking about what happens at each of these different parts of the electrical conduction system. The first one is called the sinoatrial node, or SA node. This is sometimes referred to as the physiologic pacemaker. Maybe you've heard of a pacemaker before. It can be a surgical medical implant. What does a pacemaker do for your heart? Yeah, so if you get a pacemaker implanted in your heart, it's generally for arrhythmias, and its job is to send out signals to make sure that your heart is beating at the appropriate speed and rate. To call this the physiologic pacemaker means that this is the part of your heart normally supposed to be doing that task. So the job of the sinoatrial node is to initiate the impulses that will eventually spread through the whole heart and cause it to contract. So this is one of those areas of autorhythmicity that we saw before. It brings itself to threshold and spreads those impulses throughout the rest of the heart. One of the things that we'll notice is that part of the heart will contract as the impulse goes through it. So the first part of the heart to have an impulse, to have an action potential, being the SA node, means that the first area of muscle to contract will be the parts immediately around it. And that's located in what chamber? Yeah, in the atrium. So the atria are the first chambers to contract as this impulse begins here in the SA node and spreads out from there. Okay? And in a normally functioning heart, all of the impulses begin here in the SA node. It's not the only area of autorhythmicity, but it is the only area that should be doing it if your heart is healthy. Notice here, its intrinsic rate is about 100 beats per minute. So that means that with no other input, the sinoatrial node will fire off impulses at about 100 beats per minute, which is, in case you're wondering, roughly the beat of the song "Stayin' Alive" by the Bee Gees, if you know that one. Also, Another One Bites the Dust by Queen, but the one is more. The reason why I talk about those songs is because that's also the rate they tell you to do chest compressions during CPR. So "Stayin' Alive" is both approximately 100 beats per minute and sort of a positive message when you're trying to save someone's life, whereas Another One Bites the Dust is a little bit more cynical. But that is, again, the rate that the SA node would send out signals with no other influence. Now, is this normally the rate that your heart is actually beating at, 100 beats per minute? No, if it was, you'd be in trouble, right? Normal resting heart rate, the textbook often gives us about 75 beats per minute as a normal resting heart rate. That would be considered within the normal range, but remember, this is the kind of thing that can vary quite a bit. So 75 beats per minute is perfectly fine to use as a standard for resting heart rate, but will some people be lower than that? Sure. And in fact, if you're cardiovascularly fit, you should expect it to be lower than that. So for example, if you're in pretty good shape, you might have a resting heart rate of about 60 beats per minute, or even lower. Okay? But the point is, it's not 100 beats per minute. What does that tell us? That tells us that it's, at rest anyway, always being slowed down. So what part of our central nervous system is responsible for slowing down the heart? The parasympathetic. So as you guys sit there in your chair right now, the reason why your heart is not beating at 100 beats per minute is because the parasympathetic division is always putting the brakes on. Okay? If you leave from here and go, say, have a workout over lunch, when you're exercising, your heart rate will be higher than 100 beats per minute because what division is speeding it up? The sympathetic, exactly. So, anyhow, impulses are being sent out from the SA node as we saw before, they travel through the atria and eventually arrive at the next part right here called the AV node. The job of the AV node is to delay the impulse. So it doesn't stop it completely, or at least it shouldn't, and it doesn't just allow it right through, it makes it wait a second, or more accurately, about 0.1 seconds, which doesn't seem like a lot, but it is significant. What do you think is the point of this delay in the signal? Well, yeah, you're on the right track. Remember, we can correlate this electrical activity to muscular action, right? So when the SA node generates the impulse and it travels out away from there, what chambers are contracting? The atria. Pushing blood from the atria into the ventricles. Well, what moves faster? Blood or electricity? Yeah, so we need to cause the signal to pause here at the AV node so that the blood can finish moving from the atria to the ventricles and you have complete ventricular filling. Okay? If it just zipped right along, the ventricles would start contracting before the blood had even finished moving. So we delay the signal and make sure that ventricular filling is more complete. The AV node is actually an area of autorhythmicity too. So the AV node is also capable of generating its own signals. However, in a healthy heart, it should not be, because it has an intrinsic rate of about 50 beats per minute. Now, even the fittest athletes in the world probably do not have a resting heart rate of lower than 50 beats per minute. So this should not have to take over. The AV node only takes over an impulse generation if something is wrong with the SA node, some sort of heart problem. Right? We'll talk about what that could be here in a few slides. But if the SA node is not functioning properly, the autorhythmicity of the AV node can take over at its intrinsic rate of 50 beats per minute. Is that enough to prevent you from dying? Yeah, as long as you don't really do anything, but is it okay as a long-term plan? No. So this is enough to keep you alive, but it does need to be addressed if something is causing the AV node's autorhythmicity to take over. In a healthy heart, all the AV node is doing is delaying the impulse. It will then move into the AV bundle. As I said, this is formerly known as the bundle of His. The AV bundle and the next one, the bundle branches, they work their way through this thing right here. So there's our AV bundle. These are the bundle branches. This wall of muscle that it's traveling through is called the interventricular septum. What is a septum? Yeah, it's a divider, and it's usually dividing something into right and left, right? That's what we see here. So there's our interventricular septum separating the right ventricle and the left ventricle. And you'll notice that the AV bundle and the bundle branches are traveling through it, which means that in the lower part of the heart, the first structure to contract is the septum, right, is the IV septum. Remember, it's causing contraction as it flows through. So it goes through the septum, that muscle contracts first, and notice it goes all the way down to the apex before working its way back up. So then, what is the first part of the ventricles to begin contracting? The ventricular walls. The bottom, right? Contraction will occur here first and work its way up, and here last. This is on purpose. It seems weird to travel all the way down to the bottom just to work your way back up. Couldn't these fibers have just gone down the sides like this? Well, sure they could have, but this is actually the better plan. You get more efficient ejection of blood from the heart if you squeeze from the bottom first and work your way up. Like how you get the toothpaste out of the tube, right? Squeeze up from the bottom, make sure you get it all. You know, just grab in the middle and on your toothbrush, unless you're an animal, right?
Or toss it.
Yeah. So causing the apex to contract first and then go up the sides is a way to get more efficient injection of blood from the heart. So to recap the parts of the cardiac conduction system, you've got the SA node that generates the impulses. You've got the AV node, which delays them. You've got the interventricular bundle and the bundle branches. And then finally, the subendocardial conducting network that contracts the walls of the ventricles. And that last part, the subendocardial conducting network, is also autorhythmic. But look, its intrinsic rate is only about 30 beats per minute. Which means if the AV node is no longer functioning properly, can the ventricles generate their own impulses to eject blood from the heart? Yes, they can, but at a rate of 30 beats per minute. Is that enough to keep you alive? No, probably not. So, yeah, it's got a system, but if you get this far down the line, you need immediate medical attention or you'll die. So, disorders of this. When we talk about the cardiac conduction system, disorders are things called arrhythmias. This is sort of like what we talked about in chapter 17 with anemia. Remember how we said anemia is not one thing but a group of disorders that sort of signify something? It's the same deal with arrhythmia. Arrhythmia is not a particular condition. All it means is abnormal electrical activity in the heart. Well, what about it is abnormal? Well, we haven't specified. Okay? So, abnormal electrical activity in the heart is arrhythmia. Do you guys know the word for normal electrical activity in the heart? Normal electrical activity in the heart is called sinus rhythm. Oh boy, I have to remember how to spell rhythm. I think it's... Oh, it's close enough, right? Normal electrical activity in the heart is called sinus rhythm. Any deviation from normal is called arrhythmia. We've got some different types of arrhythmias that we can look at here. The first one is fibrillation. Fibrillation it describes as rapid, irregular contractions useless for pumping blood. This is where the walls of the heart chambers, rather than contracting coherently and strongly, end up sort of fluttering and quivering. And as you can imagine, it's still moving, it's technically contraction, but it's not forcing blood out, right? And so it's not good. Fibrillation can occur in either chamber. And so you get words like atrial fibrillation or ventricular fibrillation. Sometimes abbreviated AFib or VFib. Now both of them come with their own problems, but what is more immediately life-threatening, AFib or VFib? VFib, ventricular fibrillation. If this is happening in the ventricles, you are currently dying. It's happening right now. Okay, so that's because if the ventricles are not contracting, there's no blood being pushed out to your body. And that includes very important places like your brain and your heart muscle, right? That need blood and can't have it interrupted for more than a couple minutes without serious permanent damage and probably death. So ventricular fibrillation is what defibrillators were designed to address. You have fibrillation, well, you need defibrillation, right? Those are the paddles, the shockers, the clear, that stuff, okay? That's defibrillation, which I love because what it does is it sends a big electrical shock to the heart, basically interrupting this activity, attempting to get it to restart normally again. So I think of this as the IT approach to emergency medicine. Oh, is it not working right? Well, try turning it off and back on again. That's basically what you're doing with defibrillation. Again, I like to survey paramedics that come through my class and find out about these things. The impression I'm getting from them is that this is successful approximately half of the time. So, pretty good, all things considered. Atrial fibrillation is the same event, the fluttering, but it's happening in the atria rather than in the ventricles. The reason why this is not immediately life-threatening is because the majority of the blood movement from atrium to ventricle is passive, meaning it's not pushed by muscle contraction, but rather it just sort of falls down from gravity. Okay? 80% of the blood moving from the atrium to the ventricles moves passively. The contraction of the atrium is only for the remaining 20%. So if you have atrial fibrillation and the atria are not contracting, do you still have adequate blood flow? Yeah, it's not optimal, but it's enough, right? And people live with atrial fibrillation for quite some time. The main risk with atrial fibrillation is the risk of blood clots. So that's the main thing you have to address. But blood flow through the heart is adequate, even with atrial fibrillation. Other types of arrhythmias include, we talked before about the possibility of a defective SA node. So they're talking about ectopic focus here, ectopic focus, abnormal pacemaker. When the SA node is not sending out the signals, what takes over? The AV node. Okay? We refer to that as junctional rhythm. Now, one of the main things that we noticed is that the AV node has a lower intrinsic rate, about 50 beats per minute. They're giving you a range here. We saw a solid number before, but it's right in the middle of that. And again, you can live with this temporarily, but it is a problem. We'll see when we get to ECGs and their components, we'll see some other characteristics of junctional rhythm that we can point to. But one of the main ones that we can understand right now is that it's a slower rate as a result of the slower autorhythmicity of the AV node. Now again, if the SA node is not working, and the AV node has to take over, okay, you're getting all of this contracting, but this is not receiving electrical stimulation, right? Right? But is that an immediate threat? No, because again, most of the blood will move passively. You'll still get 80% of the total blood flow. You just won't get the contraction that gives you the remaining 20. There's also something called extrasystole, a type of ectopic focus or abnormal pacemaker that results in a high rate rather than a low one. So it's not necessarily that the SA node is crapped out, for lack of a better term, but rather it's sending out signals too quickly. They say here it can be from excessive caffeine or nicotine intake. You've heard of certain things can cause a person's heart to race. So that's what they're talking about here. The SA node is sending out those signals too fast. I've also known at least one person who was a student a year or two ago here who was born with an extra SA node. So basically he had two of them. And most of the time they would sync up pretty well and he'd have a normal resting heart rate. But occasionally they'd get sort of out of sync and fire off at different times, and the result was that his heart would start beating really fast for no reason. And eventually it would pass, and they'd sync up again, and everything would go back to normal. And I said, well, what are you going to do about that? I said, well, the doctor says that unless it starts causing serious problems, we don't do anything. It just is sort of weird sometimes. But one thing they can do is go into the heart through an artery with a little cauterizer and burn off the extra SA node. Other types of arrhythmias include a heart block. A heart block is what you call it when the AV node is preventing the impulses from passing through. What is it supposed to do?
Just
Delay it. If it stops it altogether, that's called a heart block. These come in varying degrees, and depending on how technical you want to get, you can talk about first degree, second degree, etc. For our purposes, we'll talk about partial and complete heart blocks. In a partial heart block, you see some of the signals getting blocked and other ones being allowed through. In a complete heart block, they are all being prevented from passing through. This is one of the reasons why you may need an implanted pacemaker. So we already talked about regulating it. Basically, the sympathetic nervous system increases the rate, the parasympathetic nervous system decreases the rate. Next on our list of things to talk about is the electrocardiogram, or ECG. You may have also heard it called an EKG. What does that stand for?
That's what confused me. I was like, did people start spelling it wrong? Is that?
No, it's actually still electrocardiogram, but I guess this thing was originally invented in Germany, and in German, cardio is spelled with a K. And so the acronym kind of stuck. But either one, ECG or EKG, is fine. I feel like maybe the only reason why people still sometimes go with EKG is because that seems to be a little bit easier to say. ECG sort of mushes together. But again, either one is fine. When you're doing an ECG, what you're doing is measuring the flow of electrical current through the heart. And you can see it show up on the recording device. We will actually be doing this in lab on Thursday. So that should be kind of fun. And measure the electrical flow through the heart. When electrical conductivity through the heart is measured on ECG, you see three major deflections on the reading. The P wave, the QRS complex, and the T wave. And again, this is just the line moving up or down. That indicates electrical activity. Let's pull up the graph here. So this represents one normal heartbeat, one full cycle through everything. There's the P wave, there's the QRS complex, and there's the T wave. The P wave, that little bit of electrical activity, is the initiation of the impulse in the SA node, and then as it's traveling through the atrium. Atrial depolarization. So of course, depolarization, that's the electrical activity, right, that we see the impulse traveling through. And as we know, whenever the electrical impulse goes through a part of the heart, what does that muscle do? Contracts. So yes, atrial depolarization is what we're seeing because it's electrical activity. What we can infer is that this is when the atrium is contracting. Both atria act together. So it just says atrial. Well, which atrium? Both of them. Okay? Right and left acting together. Then notice we have this brief period of electrical inactivity after the atrium have contracted. Anybody want to guess the effect that we're seeing? What is that the effect of that we're seeing right there? The AV node delaying the impulse before sending it on to the ventricle. The next major deflection is the QRS complex, so the line will dip down slightly and rise and dip down again before recovering. Now this is how they always show it to you in here. This is textbook perfect. Almost nobody's looks exactly like this, and that's okay. And so when we do this on ourselves and it looks a little different, try not to freak out. It's probably nothing. And this represents ventricular depolarization. The QRS complex is ventricular depolarization. Why is it so much larger than atrial depolarization? Yeah, a lot more muscle in the ventricles, right? So a lot more electrical activity generated by that. And again, which ventricle, right or left? both, right? The two sides are working at the same time. So it's not right and left happening separately, it's top and bottom happening separately. So here the ventricles depolarize, which means the muscle is contracting. And then finally, the last event that we see on here is the T wave. This, by the way, is exaggerated. It's almost never that long. The T wave represents ventricular repolarization. This is a resetting, electrical resetting of the tissue. And it represents the ventricles relaxing and going back to the resting state. Why do we not see atrial repolarization? We saw them both depolarize, and then we saw the ventricles repolarize. Why do we not see the atria repolarize? Yeah, because it's actually happening during this time, but this is such a greater amount of electrical activity, it sort of, covers it up. So when we do ECGs on ourselves in lab on Thursday, we'll try and identify all those different parts and make correlations with what we know.